Thank you, Don. Again, my name is Dr. Chut Sombutmai. People just call me Dr. Chut for short because it's a lot easier. But anyways, I've been here at Florida Hospital East now for about 13 months. So stroke is my passion. I did a fellowship in stroke, or we call it vascular neurology. And I did my training in Jacksonville, so my parents live in Tampa, so we're I'm a transplanted Floridian. So, but in any event, the reason why it's important to kind of recognize stroke and is to basically tell you guys that we have options. Obviously, the goal is to prevent stroke, number one. There are modifiable risk factors, and hopefully our goal is to prevent you from coming into our doors. But certainly we want to get the awareness out that you do have treatment options, but you have to recognize the symptoms and you have to get into the ER right away. So here are kind of some of my objectives for this talk for tonight. Talking about TIA, what is a TIA, transient ischemic attack, ischemic stroke, different types of strokes, the symptoms that we'll talk about, and of course the acute treatment of stroke, meaning stroke that's happening within the last couple hours. And then we have something called code gray here, which is basically kind of like a heart attack protocol. But it's for a brain attack that's happening right there and then. And that's kind of what I'm talking about, is when you come in here, it's going to be a very hectic and chaotic thing, but it's to kind of give you all the treatment options that we can. We call it code gray here in the Florida hospital system. So TIA, it stands for a transient ischemic attack. Basically, transient, the symptoms come and go. Ischemia, meaning lack of blood flow, whether it be because a blood clot's in the artery or you're not getting blood to that part of the brain. So again, TIA stands for a focal neurological change attributable to dysfunction of the brain that is transient, usually less than 24 hours, and does not result in brain damage. And that's kind of the key difference between TIA and stroke. TIA represents a stroke warning sign that could result in permanent brain damage. Okay? Stroke is defined as also an acute neurological injury to the brain due to ischemia, like I said, lack of blood, or hemorrhage, bleeding into the brain, a bursting of the blood vessel, causing permanent brain damage. Usually our TIA patients, when you come into the hospital, you get admitted, you get a brain MRI, and that usually is negative for stroke, or ischemic stroke anyways. So a little bit about how often, or the prevalence, or how pervasive TIA is here in the United States. At least people who can report the symptoms of TIAs, that acute neurologic change. One moment you're normal, the next moment you're having neurologic symptoms. That usually is about 2.3%, or about 5 million people. But we think that TIA is actually more is around in the community greater, because people kind of don't report their symptoms, whether it be numbness on one side, they think, oh, I slept on my arm wrong, and then all of a sudden now they're weak, and so like, okay, maybe there's something else going on. TIAs is different than heart attacks. Heart attacks, they hurt, and so you want to go to the ER and you want the symptoms to stop. Unfortunately, with strokes and TIAs, they take away symptoms, so you're numb, you're weak, what we call negative symptoms. And so you don't want to believe that you're having a stroke, and so sometimes you sit on it, and sometimes doing that could be too late. So 50% of all strokes, again, strokes being kind of that permanent brain damage, are preceded by a TIA. So that's why a TIA is a stroke warning sign. We treat TIA and stroke, the same. Just that TIA gives us a chance to, catch your symptoms and maybe, find out why you could be having a TIA and then going on to having a stroke. So your short-term risk of a stroke after a TIA, meaning that, what is my risk of having a stroke after a TIA if you sit on it, is between 3 and 10% after 2 days. And then, or after 3 months, your risk of having a stroke, again, brain damage, is around 9 to 17% after a TIA. Now, for those who have the TIAs and you survive the 90-day period, your 10-year risk of stroke is around 20%. But it's still pretty high. I mean, that means that within the 10 years, you have a 20% chance of having a stroke. And it's even higher if you include stroke and heart attacks, what we call vascular events. It's as high as 43%. So it is kind of a bigger warning sign that something needs to be addressed, whether it be blood pressure, diabetes, cholesterol, or some type of other blood vessel problem. Now, within 1 year of a TIA, around 12% of patients will pass away. And actually 1/3 of episodes that would be considered TIAs, or symptoms that come and go, are actually, they show up as a stroke on the brain MRI. Now, strokes, or at least TIAs and strokes among adults aged greater than 20, the estimated prevalence of stroke is around 6.4 million per year, 2.5 million in males and 3.9 million in females. Females tend to be affected more for some reason from stroke. Each year, about around 800,000 people experience a new stroke or a recurrent stroke. As you can see by the number, 610,000 people get their first stroke, and then 185 with a recurrent stroke. And then on average, every 40 seconds, someone in the United States is having a stroke. And this number is always the 1.9 million neurons, the brain cells. So for each minute, if you're going through a TIA or even a stroke, you're not getting blood to the brain, you're losing 1.9 million neurons a minute. So that can cause significant disability and leading to other problems down the line. So each year, again, I mentioned about women. For some reason, 55,000 more women than men have a stroke. Women accounted for around 60% of stroke deaths in 2006. Typically, I think the reason why women tend to last longer than men, and then stroke in women seem to occur a little bit older. On average, men have it around age 71, and women have their first stroke around age 75. And then there is an issue with menopause. If you go through natural menopause before the age of 42, for some reason, that also increases your risk of having a stroke compared to a woman who has natural menopause after 42. And I guess natural menopause meaning like you don't have, for some whatever reason, if you had ovarian cancer in your 30s and they have to take out your ovaries, that would be kind of something that is not natural. But this is the evolution of menopause. So also, ischemic stroke can happen in younger women, also during pregnancy, and I kind of wanted to bring this, stroke can happen to anybody, young, old. What's the interesting statistics is that, women after the birth, the postpartum period, they have like around the 6 weeks time frame, you have a 2.4 times greater chance than a non-pregnant woman when you compare age and race to having a stroke. And I think this is probably due to we do have a little bit more high blood pressure and heart disease in this time frame as well, and that can kind of lend towards why it's so important while you're pregnant to keep an eye on your blood pressure and make sure that you treat it. And also that includes diabetes during what we call gestational diabetes during that time frame as well. So all of that can increase your risk of having a stroke. African Americans and Hispanic populations have a higher incidence of stroke compared to the Caucasian population. This is probably due to maybe access to health care, maybe not accessing into the medical system, but our African American population, they do tend to have more high blood pressure and diabetes as well, and same goes with our Hispanic populations. As far as stroke, 87% are mostly ischemic, meaning lack of blood flow, a blood clot. 10% are from intracerebral hemorrhage or bursting of the blood vessel, then bleeding into the brain. And then there's a small subset of bleeding in the brain called subarachnoid hemorrhage, which is usually caused by an aneurysm in the blood vessel that bursts open, and then you bleed into the deep grooves of the brain. So we call that subarachnoid hemorrhage. But most of the strokes that we deal with are related to lack of blood flow and a blood clot affecting blood flow to the brain. So strokes accounted for 1 out of every 19 deaths in the United States in 2009. Stroke now ranks as a number 4 cause of death behind heart disease, cancer, and chronic lung disease. Several years ago, I think about 5 years ago, we were the number 3. So chronic lung disease has moved up, and we're making a difference, but we want to improve on that. And then I mentioned every 40 seconds someone has a stroke in the United States. Every 4 minutes someone dies from a stroke in the United States. And compared to looking at people ages 45 to 64, 8 to 12% of the ischemic stroke patients and 38% of the hemorrhagic stroke patients die within 30 days. So the bleeding stroke, while it only accounts for 10% of all strokes, it's usually the more fatal type of stroke. Now, there is something called the stroke belt, which predominantly involves the southern states. The stroke belt states are North Carolina, South Carolina, Georgia, Tennessee, Mississippi, Alabama, Louisiana, and Arkansas. And then there's a small part called the stroke buckle, which I think includes the Carolinas and Tennessee. So you can kind of imagine if it's like that little small part of that beginning of the belt. But the reason why the stroke belt is so important is the mortality or the death rate is high. And, it's 20 compared to the national average. It's 20% higher in the stroke belt and even higher in the stroke buckle, around 40%. So stroke is very prevalent in the South, and I would even include, the top Florida, where I trained in Jacksonville. Stroke was very prevalent as well. So I would probably include northern Florida, but stroke is everywhere. But in the South, it's very predominant and causes a lot of death and disability. So stroke is the leading cause of long-term disability. So stroke, I always tell patients, strokes, it doesn't kill you. It's the number 4 cause of death, but it's the number 1 cause of disability. It unfortunately leaves you disabled. And that disability can range anywhere from having mild deficits where you might need a cane, or to significant impairment where you are having to be in a nursing home and needing feeding tubes and things. And I've seen the entire spectrum of what stroke can do to our patients.
Excuse me, I got a question.
Yeah.
How can stroke kill you?
Well, it depends on the type of stroke. The stroke, if it's a bleeding stroke, the blood can expand and compress on the brain tissue. Again, you got a hard skull there, so you got nowhere else to go. The brain pushes down, and then you stop breathing, and then it can take you out. So as far as bleeding strokes, the blood clot strokes, it can be the same thing. You don't get blood there. It can cause swelling, and it could potentially cause you to die as well. Or even long term, if you're disabled where you need to be in a nursing home, you usually end up dying of the consequences of immobility. So bed sores, pneumonia, and things like that, urinary tract infections, bacterial infections and things like that. So it's not just the actual process of the stroke. Sometimes if you survive it, then you become disabled, then there are long-term consequences that can cause you to pass on as well.
Does it affect also like certain ethnic groups more than others? Or?
Yeah, predominantly it affects mostly African American and Hispanic populations, but it can also affect Caucasian populations as well. And there is more of a southern predominance, like I said, in the stroke belt. Okay, so and kind of coming off of that, after your first stroke, the women do tend to survive a little bit longer, and the older you are after your first stroke, the less likely the survival time is smaller. So for between 60 and 69, after your first stroke, around seven years survival time for men and 7.4 for women. And again, as you can see, kind of the trend when you're between your 80s and older, men 1.8 is their survival time versus 3.1 for women. Most of our patients, 45%, are discharged to go home, so that's pretty good. That's almost half. But of those who go home, around 32% will require home care services, whether it be home physical therapy, occupational therapy, working with your arms, as well as speech therapy. Now, 24% of our stroke patients go to inpatient rehab facilities, meaning that they go to like a rehab hospital where they get intense therapy 3 hours a day. And then 31% go to a skilled nursing facility meaning it usually is a nursing home, and they usually work on rehab about 1 hour every day. And then 1/3 of our stroke survivors, they do experience, post-stroke depression, which definitely can affect their will and drive to get better. And I will say that after you have a stroke, rehab is very important. Once you have brain damage, it's done. And the goal is then to prevent the next one and to also recover from the current one you have. And usually the maximum period of when rehab is so important is when that first 3 to 6 months. So as soon as you have your stroke, our goal is to get you to rehab, whether it be to home or to one of these facilities where you can start working on getting better. And then over time, hopefully minimize your disability. So our goal is to have no disability, but sometimes you may have minimal disability. So as far as the costs, of stroke in 2010, it was around 74 billion. By 2030, it's looking like the annual cost of stroke will increase to $240 billion. And then around 4% of the population greater than the age of 18 is projected to have had a stroke, which is a lot compared to when you think of how many hundreds of millions of people we have. Also, like I mentioned, stroke is on the rise in young adults. There was this study here that they looked at discharge data from 1995 to 2008, and it showed that for the age group of 15 to 44, the diagnosis code for stroke went up to 30-37% for patients. This also coincided with more high blood pressure, the hypertension, the cholesterol, high cholesterol, diabetes, obesity, and tobacco use. And this was kind of a breakdown from the study. When you look at for men and women, they're a little bit different. It's a little bit higher in men, but for ages, 35 to 44, there was a 50% increase in men who were discharged with stroke, and then 46% between the ages of 15 and 34, and even between the ages of 5 and 14, there was a 51% increase. And then for women, you kind of see the increase wasn't as bad, 29%, 23%, 3%. But ultimately, though, I think what we're seeing is that there is more high blood pressure and diabetes in the community kind of creeping into these younger age groups. So let's talk about risk factors. Hypertension is probably the biggest risk factor for having a stroke, an ischemic stroke, or even a bleeding, a hemorrhagic stroke. If we can, I think one of the stroke doctors in the nation said, if we can eliminate hypertension, you can see here, you can probably eliminate 80% of all strokes. And so usually, most of our stroke patients, when they come in here, they usually have high blood pressure. And then the statistic here, around 77% of those who have a first stroke usually have a blood pressure greater than 140/90. And it's even worse in diabetic patients who have high blood pressure. Having a blood pressure less than 120/80 will cut their lifetime risk of a stroke by 50%. So it's even more important if you're a diabetic to also watch your blood pressure as well. We also have high cholesterol, physical inactivity. More data is showing that if you have moderate to vigorous physical activity, it's associated with a 35% reduction in the risk of stroke. And usually moderate vigorous activity is defined as kind of getting your heart rate up, for about 30 minutes. So usually a nice brisk walk, 3 to 5 times a week would probably suffice. Again, I mentioned about diabetes. So high blood pressure and diabetes, those are the two big ones that increase your risk of having a stroke. As you see here, I said ischemic stroke patients with diabetes mellitus are younger. They're more likely to be Black and more likely to have high blood pressure, heart attacks, and high blood pressure than in non-diabetic patients. And in people with a history of TIA or stroke, we have something called impaired glucose tolerance, or kind of like a pre-diabetes range. It nearly doubles your stroke risk compared to someone who has normal glucose levels. And if you already have diabetes, it triples your risk of having a stroke compared to someone who has no diabetes. The big one, disorders of heart rhythm, is an under-recognized problem. The big one is atrial fibrillation, or AFib. It's a definitely not treated aggressively enough. Usually this is, the discussion has to be in conjunction with your cardiologist or a cardiologist. But if you have atrial fibrillation, which again is a arrhythmia of the heart, it increases your risk of a stroke by 5 times compared to someone who doesn't. And so atrial fibrillation is a risk of aging. As you can see here, around between ages of 50 to 59, the percentage of stroke attributed to AFib was only around 2%. But if you go to 80 to 89, around 24% is due to atrial fibrillation. And so usually what I see in patients who don't have high blood pressure, who don't have diabetes, who don't have cholesterol, if they're a little bit older in their 70s and above, sometimes I worry about this condition, this atrial fibrillation. Smoking is also a big one. Current smokers have a 2 to 4 times increased risk of stroke compared to non-smokers or those who've already quit smoking greater than 10 years. And also cigarette smoking is a risk factor for the subarachnoid hemorrhage, the aneurysm that bursts open and bleeding into the grooves of the brain. And a lot of people ask about secondhand smoke. It does seem to increase slightly your risk of stroke for whatever reason, but definitely smoking does increase your risk of having a stroke significantly. Family history and genetics. If your parent had a ischemic stroke before the age of 65, it does confer that you have a 3-fold increase in ischemic stroke in your offspring. Chronic kidney disease or impaired renal function can also increase your risk of stroke. And sleep apnea is now being identified as a potential risk of stroke or heart attack. As you can see here, stroke or death by 2-fold compared to someone who doesn't have sleep apnea. So people with severe sleep apnea have a 3 to 4-fold increased risk of stroke. And sleep apnea can happen also after you have a stroke. And depending on if you go through rehab, hopefully your sleep apnea goes away. But sleep apnea is definitely one risk factor that is under-recognized.
I have a question. What about jet lag?
Jet lag?
Yeah.
No.
That also increases?
No. No jet lag. That's a new one for me, man. So let's talk about stroke types. So what we're talking about is, kind of why, the process, the mechanism of stroke. So we kind of break things down this is the ischemic part, the lack of blood flow. So one subtype is called thrombotic strokes, okay? And basically you form the blood clot within the blood vessels. And of course, if you have a blood clot there, you're not getting blood to that part of the brain. So it causes obstruction of an artery or leading to distal ischemia. So meaning that you have a blood clot in one part and then it kind of goes down the river here. And then it clogs the river downstream. So we have large vessel disease, meaning we have the carotids, the bigger blood vessels. We have 2 internal carotids in the front and 2 vertebral arteries in the back. And then intracranial vessels, it just means that the big blood vessels in the brain. And then the small blood vessels are those little tiny blood vessels that come off of the bigger blood vessels. And usually patients who have high blood pressure, who smoke, and have diabetes, it's usually the small vessel disease, the tiny little blood vessels that come off, that cause these strokes that are deep in the brain, and we call them lacunar strokes. And so here, you can kind of see, this is called the middle cerebral artery. So, it's a nice, big, beefy artery. This is kind of like the Mississippi River. And then you can see there's little tiny tributaries that come off deep into the brain. And then, the Mississippi River, it branches off and goes to the surface of the brain. So like these little smaller, tiny blood vessels, what we call, in this case, we call it the lenticular striate arteries, but these are the little tiny blood vessels that go deep in the brain. This is what we call the small vessel disease, the smaller blood vessels. So you can always have a blood clot that, that plugs up this, area. So you can imagine if you have a blood clot here, you're not getting blood to a good chunk of your brain. But if it's just one of these little tiny blood vessels, and usually it's more than just one, it's usually a couple of blood vessels. But if it could be enough that you have strokes deep in the brain, we call lacunar strokes, and then causing you to have have neurologic symptoms. But again, it's the small vessel disease, the high blood pressure, the diabetes, the high cholesterol, the smoking. It usually affects these little tiny blood vessels that come off of the bigger blood vessels. But you can still have disease and hardening of the arteries that affect the big ones, big blood vessels as well. And then we have something called embolic strokes. So a blood clot forms in one part of the body and travels up to the brain. The more common area is the heart. So as I mentioned, there's the atrial fibrillation or AFib. It causes the heart fibrillates, it forms blood clots and goes up into the brain and causes problems. So usually the heart is where when you come in and you get evaluated for a stroke, we want to check out your heart. We want to make sure there's no blood clots identified in the hearts or the heart valves are okay. Then there's the aortic arch, which comes off of the heart. Sometimes there's cholesterol plaques there as well. And there is what we call paradoxical embolism, where usually you have to have a hole in the heart and then a blood clot in your leg. That's usually the common scenario. You get a blood clot in your leg, it travels up to the heart, crosses over through the hole, the PFO, and then goes up into the brain and causes the stroke. Now, cryptogenic stroke means a stroke that we don't have a cause for. So it's actually a high, 20 to 30% of patients that come in the hospital, we can't find the reason why they had a stroke. Their blood pressure is good, their diabetes is good, their cholesterol is good, they don't smoke. So we try to identify what else could be the cause of their stroke. For me, anyways, my experience, I usually see it's the AFib, because it's our older patients that come in, everything is good, they work out, and then, as I mentioned, as we get a little bit older, your risk of having AFib increases. So that's usually, the smoking gun that I try to look for is atrial fibrillation. And then, of course, the other big stroke type is the hemorrhagic stroke or bleeding stroke, where you can bleed in the brain, and that's usually caused by uncontrolled high blood pressure. It could be caused by a spread of cancer sometimes that goes into the brain and bleeds into your brain. And then I mentioned there's that other small subtype called subarachnoid hemorrhage, where an aneurysm bursts open and you bleed in the brain as well. And just remember, the bleeding stroke is the kind that you do worse. So a little bit about stroke symptoms. Usually, again, you're normal in one point, and then all of a sudden, boom, you have symptoms. So some of the things that we tell you is kind of that sudden numbness or weakness of the face, arm, or leg, and it's usually on one side of the body. So the one side of the brain controls the other half of the body. So usually, we try to look for that. One side is normal, the other side there's a problem. Also, sudden confusion or trouble speaking or trouble getting your words out or understanding your loved ones, trouble seeing in the eyes, trouble walking, whether they have dizziness, kind of vertigo type symptoms, room spinning, or loss of balance or coordination. Usually the other type of dizziness that most people feel is lightheadedness, and that's usually not from a stroke, but certainly the dizziness that we try to look for is vertigo or that room spinning or feeling drunk or off balance, and especially if it comes out of the blue, that could be consistent with a stroke. And usually sudden severe headaches out of the blue, like you got hit by a hammer, that usually what we're trying to look for is hemorrhage or bleeding in the brain. So you can just imagine you're doing fine, and all of a sudden, boom, the blood vessel bursts open, you have this severe headache, you need to call 911 immediately because you could be having a bleeding stroke. So you probably got these cards, we call them the FAST is the acronym. So F stands for face, so you want to ask the person to smile, and you see if there's a asymmetry. One side doesn't move better than the other side. You go to arms, ask the person to raise both arms and see if there's a drift on one side. So certainly right now at this point, if you go through it, you go face, you're like, okay, they're not smiling, they can't move the right side, and then all of a sudden you see you do the arm part, and then they're like, oh, wait a minute, the right arm is now, so everything is matching up on one side. That definitely could be a sign that they're having a stroke. And speech, is it slurred? Are they saying inappropriate things, not answering the questions, just kind of out of the blue. And then T for time. Time is brain, which we will talk about later as far as what we can do for our acute stroke patients. So the code gray process usually happens in the ER. Identify the acute stroke patient. So that usually happens in the EMS, in the 911 period, where you have to be kind of attuned that, wow, I think I'm having a stroke or my loved one is having a stroke, and call 911. The EMS personnel would come, they evaluate the patient, they kind of do the same thing, and if they think you're having a stroke, they're going to whisk you away and bring you to the closest stroke hospital, and then we have that discussion about what we can do for you. Usually, you identify, you call 911, you get picked up, you get rushed to the hospital, and also I would encourage, if you think someone is having a stroke, call EMS, because if they think you're having a stroke, they call us ahead of time. They call the ER, they say, hey, I think we might have a stroke patient, we're giving you a heads up. A lot of times, when patients who drive in, or you drive your loved one into the hospital, we may not be able to recognize it, or the triage person might not be able to recognize it as fast. So really the thing to do is to call 911, get the emergency crew there, they'll look at it, and then they'll usually call the ER doctor and say, hey, I think I might have a stroke patient coming your way. And so that same thing goes, the ER doctor will assess the patient and say, okay, I agree with you, I think they are having a stroke. And I'm kind of describing what the process goes on here in the Florida hospital system. They usually call the stroke doctor. There's a handful of us in the neurology department that take stroke call. So we're on call, and we field these calls about potential patients and their stroke symptoms. Usually the ER nurses will descend on you, and they'll try and get blood work and try to get you to the CAT scan to see if you're having any bleeding in the brain, or anything else, if they can see a blood clot in the brain as well. Usually by then, we, as a stroke neurologist, you'll probably, at least in the Florida hospital system, we will evaluate the potential stroke patient via a televideo monitor. So you're in the stretcher, and then you'll see my face on this camera, and then I'm asking you to do things, and that's kind of what that entails. That's what we offer here in the Florida hospital system. I'm not sure if every hospital has this technology, but at least by us evaluating you via the video process, we can kind of rapidly give you the treatment if you're eligible, and that's that last part here. If you're, the medicine is called TPA. It's given intravenously. If you're eligible, your labs are okay, you don't have any signs of bleeding on your CAT scan, and of course, if the history, everything is consistent with the stroke, and then if everyone accepts the risk and benefits of TPA, we go ahead and give you the clot busting medicine, or TPA. So we kind of have these. The time we put certain standards to ourselves, and at least at a primary stroke center, and so these are what our goals are. So hopefully by the time that you come into the ER, that you'll be evaluated within the first 15 minutes of having stroke symptoms, or at least when you hit the door. And then you'll be rushed off to the CAT scanner within 25 minutes when you hit the door in the ER. And then, of course, hopefully by then we'll get results for the CAT scan. And then our goal is to try and give you the TPA, the IV medication, from the time you hit the door to when we make the decision within 60 minutes. So what is this stroke treatment for stroke? It's called TPA, or alteplase. So it's been around since 1996. It is FDA approved as the first treatment for acute stroke. The decision was based on a 5-year study called the National Institute of Neurologic Disorders and Stroke Study, and it was published in the New England Journal of Medicine in December of 1995. And so a little bit about TPA. Actually, we all make TPA. It's a naturally occurring enzyme in the body that naturally, when activated, dissolves a blood clot. So this activase, or alteplase, is a kind of a genetically engineered form of the TPA, and usually we give it's a weight-based medicine. So that's why we also have to ask you, how much you weigh. So we usually give you a 10% bolus over a minute. So we infuse it over 1 minute, and then the other 90% it gets infused over an hour. So from the NIN study, that stroke study that got TPA approved, they did use a 3-hour window. So from the time that you had symptoms to the 3-hour, that's what was studied. At least 33% of patients treated in the study within this 3-hour window did better than untreated patients to recover where they have little or no disability. Also, the study showed that the length of stay was shorter in the hospital. For patients who got TPA, it was 10.9 days compared to non-treated patients, around 12.4 days. Also, TPA patients tended to return home following discharge rather than to a skilled nursing facility or a rehab center. And so we talked about the rising cost of medicine. This is one way that we can kind of get you home rather than going to the rehab center or keeping you here in the hospital longer. So the biggest thing, because it is a clot-busting medicine, the most serious risk associated with intravenous TPA is bleeding. Around 25% of the patients will experience minor bleeding, whether it be bleeding of the gums or nose bleeding. But the one that we all worry about is bleeding in the brain. And your risk of bleeding in the brain, based on the study, is 6.4%. And that bleeding in the brain, we call it symptomatic intracranial hemorrhage, meaning that it could make your symptoms worse. So you come in, and 6.4% of the patients, after giving the drug, bled in their brain, making their symptoms actually worse. So I know it's probably hard. Oh no, it is pretty good to see. So this is us taken straight from the paper. This is something called the NIH stroke scale, NIHSS, and basically it's just kind of like your symptoms that you have. So placebo means they didn't get medication, and TPA is the drug. And so 0 to 1, 0 means you have no symptoms. 1, you have mild symptoms, but the 31% of the patients who got the medicine got to 0 to 1, and only 20% of the patients who got nothing got into 0 to 1. Again, 0 being no symptoms, 1 being very mild symptoms. And then there's something called a modified Rankin scale, which is a scale of disability. So 0 is you're completely back to normal, you're walking, you're independent, you're doing your normal things. And 1 is kind of like, yeah, you're pretty much back to normal, but you have some mild symptoms. And then, basically 5 is like you're bedbound and you're in a nursing home and you require 24-hour care. But ideally you want 0 to 1, that's where you want to fall if you've had a stroke. And so 26% of the patients who got nothing achieved a 0 to 1, and 39% of the patients who got the medication achieved a 0 to 1 at 3 months. So the TPA patients did better, less disability, and less symptoms after 3 months. Now, this was another study. So, the initial study was at 3 months. This study looked at how did they do at 12 months. And you go back to the modified Rankin scale there in the middle there, and you can see that the TPA patients, again, 0 to 1 is pretty good. Again, 0 is you're completely back to normal. 1 is you're pretty much back to normal. You're able to do most of the things, but you might have very mild symptoms, but it's not impairing you. So you want to be 0 and 1. At 12 months, patients who got the medication, 41% still achieved a modified Rankin of 41% of 0 to 1. So that's good compared to patients who didn't receive it, only 28% at the 1 year mark. So the TPA, it extends all the way to at least 1 year as far as benefit goes. So kind of like when I have this discussion with patients about TPA, the risk and the benefits, I will tell you 1 in 3 patients or 31% improve with the medication at 3 months, and 1 in 5 patients or 20% improve without the TPA at 3 months. The reason why I mentioned the 3 months is because when they looked at initially the patients at 24 hours, there was no benefit, but when you started following them beyond, it was around that 3-month mark where you started seeing that benefit. Again, there was that 6% chance of symptomatic hemorrhage, where again you bleed in the brain, it can make your symptoms worse. And then of the 6%, 3% were fatal. It did result in their death. Now, so that was the 3 hours. So from 0 to 3 hours, that's FDA approved for TPA. What's not FDA approved is what we call the extended window, so 3 to 4.5 hours. But this is pretty much the standard of care now in most stroke hospitals. So before it was 0 to 3 hours, and now we are able to extend it to at least 4.5 hours of when you had your stroke symptoms. So there are certain extra criteria that we have to go through, but we now can give you the IV TPA up to 4.5 hours of when you had your symptoms. Now, what happens after 4.5 hours? So there are a couple of options. There's something called intraarterial TPA, which goes up to 6 hours from when you had your stroke symptoms. And basically what that means is you would get a catheter that goes into the groin, go all the way up to the brain if we identify if there is a clot, and they would actually inject the TPA right there. So usually from the 0 to 4.5 hours, you get the IV, it's all intravenous, and then intraarterial is the, if you can't get the IV because you go beyond the 4.5 hour window, if there is a blood clot there, you can actually inject the TPA at the blood clot. And then we have a retrieval device that can extend up to an 8-hour window, and there is something called the Solitaire Device, which I think I have a picture. So basically that's kind of what it looks like. So again, you get a catheter in your groin. It goes all the way up to where the blood clot is, and the radiologist or the interventionalist, he would put this little coil thing in there and basically, remove it, and then you have that. So that's I think a couple weeks ago, someone who got the retrieval device, and that's their blood clot. Looks like one of those leeches. So a little bit about kind of what you're getting about imaging of stroke. You hear CT scans, CT angiograms, CT perfusion, MRIs. So basically, everyone gets a CAT scan. So I kind of tell everyone that it's basically kind of a screening tool. It's a big X-ray of the head. We want to make sure you don't have a big brain tumor in the head, or we want to make sure that you have bleeding in the brain, because obviously we don't want to give you a clot buster if you actually are having bleeding in the brain. So everyone gets a head CT, and a CT angiogram, all it is a dye. We inject dye and we watch it flow up in your neck and your head, and we want to identify if there are any narrowings or any blood clots. That's kind of where we try to identify the blood clot with the CT angiogram. And then a CT perfusion study is kind of like another fancy CAT scan where we take the dye and we measure how fast it flows, and we take that information and we see are you having a big stroke, a small stroke, or can we actually save your brain tissue before it dies. And then MRI of the brain is usually a better test to look for a stroke, as far as the timing of when you had it. An MRI can show a stroke that's happening within the first 2 hours of when the symptoms started. A CAT scan, just because your CAT scan is normal doesn't mean that you're not having a stroke. Usually by the time we see a stroke on a CAT scan, it's about 6 hours old. So, but the MRI, sometimes we may wish you off. If we're not sure if you're having a stroke, we may wish you off to the MRI scanner. It usually tells us, especially if you're having symptoms within the first 2 hours, and it was positive, then we might have something to go on. And then the cerebral angiogram is also that catheter test that I mentioned about going in the groin and going up and getting the blood clot. And usually the stroke workup here, usually what you get when you get admitted to the hospital, you get an MRI of the brain. MR angiogram just is an MRI technology to look at the blood vessels. I mentioned the CT angiogram. Sometimes we'll do carotid ultrasound, which is kind of an ultrasound of the of the blood vessels, and then of course the echocardiogram, which is an ultrasound of the heart. So this is kind of an example of a CAT scan, and you can see that white thing that's there. This is the MCA blood vessel, and that red or that bright spot there is a blood clot. It's there. It's acute. It happened within the first couple of hours. So when I see that, I do get a little nervous. Now this is kind of an example of what, kind of like I mentioned, if you get a CAT scan and you already see a stroke on the CAT scan, it's probably already 6 hours and beyond old. And it kind of looks like it's like a little bruise of the brain. That's kind of what a stroke would look like on a CAT scan. And you compare that to the other side. The other side, you see the grooves of the brain. This side, where the stroke is, it's swollen, and that's what happens after you have a stroke. The brain kind of swells because it's not getting blood there. This is an example of an old stroke. So you can kind of see how everything is black, and that's kind of what an old stroke looks like. And that's hopefully what we want to try and prevent. I mean, this is a big stroke on the right side of the brain there. And this is kind of what a CT angiogram looks like. It's that dye test that I mentioned. So you can see, we look at the blood vessels. This is in your neck, and then this is what your head looks like. Here on this left side there, you can see, on the right side, everything is flowing. You get all this contrast, and the blood's going there, and it's not as apparent on the left side of the brain, as you can see right there. It kind of stops right there, and there's probably a blood clot sitting right there. This is an example of what we call the subarachnoid hemorrhage. So you have all this white stuff, unfortunately, is blood, and they're bleeding all the way around in the brain. And the arrow is pointing to an aneurysm that probably burst open. And this is what a cerebral angiogram looks like, that catheter where you put it in there, we inject the dye, and then you can still see the aneurysm right there. And this is kind of what an MRI looks like. In this picture here, this is an old stroke on the left side there, and then this white spot that pops up, that's the new stroke. So that's what we're looking for when you come in. If it comes out bright on this image, on this sequence of an MRI, then you have an ischemic stroke.
Why is it asymmetrical? The new stroke.
What?
The new stroke is like asymmetrical.
Yeah, well, the right side is normal, and then the left side is, he's had an old stroke on the left side, and now he's having a new one on the right side.
Okay.
Yeah. And this is kind of, and that's the thing, to answer, I mean, that's the asymmetry of things. Strokes usually hit one side of the brain. It can hit both sides of the brain, but usually it only hits one side. And this is kind of an example of two old strokes on each side of the brain. Looks pretty symmetrical. And this is kind of what an MR angiogram looks like. It's just, again, looking at the blood vessels, but using MRI technology. Okay, so to conclude, time is brain. The quicker we can recognize a potential ischemic stroke patient, again, lack of blood flow, we can administer the IV TPA and better the outcome of patients. Again, around 2 million neurons die per minute when you're having an acute stroke. Time of onset is a very important piece of information for us. We need to know exactly when they were either normal or when, if you're like standing and you see them having the stroke involve you, we need that piece of information because again, it's very time sensitive. Unfortunately, sometimes we get into the scenario where if you hadn't seen someone normal like the previous evening, they go to bed and then you come in the next morning, we're like, that's a huge time frame, and unfortunately that we would not be able to give you the IV TPA or your loved one the IV TPA. So definitely that time of onset is very important, and while during the hectic process in the ER, we're going to try and push you, as stressful as it is, we're going to try and push you for that time of onset. We do have options for acute, for the acute treatment of ischemic stroke, the IV TPA, the sucking of the blood clot. Sometimes if you're eligible, we can do both. We do IV, so it kind of loosens the clot, and then we suck out the clot. We right now, we're having a trial called the Swift Prime trial that's only being done at Florida Hospital Orlando, and we're looking at for patients who have a stroke. We identify a blood clot, we give them IV TPA. Right now we're seeing which patients do better, just the IV TPA or the IV TPA and sucking the blood clot out. So right now that's one ongoing clinical trial we're having over there, and then so hopefully we can get more information on that, because right now it is not sucking of the blood clot is not FDA. It's not an FDA approved treatment. if you believe in the FDA having control over everything. And then of course, stroke care requires a team approach. From the ER nurses, the floor nurses, Don, my stroke coordinator. We have to stay on top of the education and letting you guys know that we can do something for stroke, for acute stroke. No longer, in like 20 years ago, when you have a stroke, sometimes they just put you in the corner of the ER and they admit you, and that's it. Now we can do something if you have a stroke, but ultimately, hopefully, the risk factors that I went through, hopefully we can improve those risk factors before you even get to this point. But we do have options, so thank you.